I'm Alison Pask, and it's a pleasure to be hosting this webinar with today's guests, Dr. Sarah Gerritsen and Professor Claire Wall. Welcome. We look forward to hearing more details about the Growing Up in New Zealand study that's been following more than 6,000 children since birth, detailing their lives every couple of years. And this large cohort study research is focused on what works to optimise child development and well-being. And it's released interesting findings, particularly about what young children in Aotearoa are eating. And there are many, many other things that this research looks at. But today we've asked Claire and Sarah just to cover a few of the key nuggets from this research related to eating. So kia ora to you both.
Tēnā koutou, yes, ko Claire Wall tōku ingoa, hei Professor aho I te whare wānanga o Tamaki Makaurau. A really warm welcome to everybody, and thank you so much for joining us for this seminar. I hope you're all keeping well in your various states of lockdown. Both Sarah and I in Auckland, so we're unfortunately not able to be in the same room, so we're going to try and coordinate this from our respective homes. Just to say that I work at the University of Auckland. I'm head of the discipline, or the department as we are now, of nutrition and dietetics, and I'm the named nutrition investigator in Growing Up in New Zealand, and I've been very fortunate to have been with the study, as Alison said, since its inception. So thank you. So over to you, Sarah.
Tēnā koutou katoa. So here's Sarah Gerritsen tōku ingoa. Here's Senior, ko Sarah Gerritsen tōku ingoa. Here's Senior Researcher aho te whare e wānanga o Tamaki Makaurau. So thank you for having us, Alison and Margaret. Thanks for organising this ANA webinar. We're really pleased to be here to talk to you about the Growing Up in New Zealand study. So I'm going to share my screen now, and then we're going to kick off.
Going. So just while Sarah's doing that, what we've tried to do is align the slides slightly to the right. So if you want to put the video part to the left-hand side of your screen or your device that you're using, then hopefully that the little video boxes won't cover over the slides. So we're hoping that that will work for you. So we're here today to talk about, obviously, growing up in New Zealand, and just really looking at some of the really key nutrition related findings from the first 10 years of this remarkable cohort study. So Sarah, next slide. So many of you probably know about Growing Up in New Zealand itself, and Alison gave us a really good introduction, but just as a little bit of a recap, the purpose of it really is to provide up-to-date population relevant picture of what it's like for children to grow up in New Zealand in the 21st century. And the really unique thing also about this study is that it recruited women during pregnancy. So a lot of birth cohort studies start, during the first year of life, but the really unique thing about our study for New Zealand is this actually recruited women while they were pregnant, and then has followed up obviously the children subsequently. So they recruited about 6,853 children before their birth in 2009-2010. So the children are between 11 and 12 years of age now. And partners were also recruited and interviewed during that time when the women were pregnant in the antenatal data collection wave. The cohort, in terms of where they were recruited from, ensures that the data is broadly generalizable to the current New Zealand births, including diversity, ethnicity, and family socioeconomic status. So the study is adequately powered, I suppose, to consider most outcomes for children who identify as Māori, Pacifica, Asian, as well as New Zealand European. And it really takes this kind of life course approach to truly trying to understand the elements and issues that are associated with growing up in New Zealand as a child today. And if you want to know more, sorry, Sarah, if you want to know more about the actual study itself and the design of the study, there are, we've got references on each of the slides, and obviously these slides will be made available as well. But yeah, so you can actually read about the structure of the cohort and the recruitment, etc., in this publication here that's on this slide. Thank you, Sarah. So it's important to understand about, the information that's obviously been collected, so that when we think about diet and food and nutrition, it gives you an idea about the context of how that information is being collected and when it's being collected. And so this sort of table shows you the different data collection times across the top, so antenatal, 6 weeks, 35 weeks, 9 months, 12 months, etc. And then it shows you the way that those that the data was collected. So whether it's face-to-face or phone interview or electronic. So most of the main data collection waves to date have all been done really face-to-face in the participants' homes, interspersed with some obviously phone calls and other electronic data capture as well. Now the little red boxes I've noted on there, the little tick boxes, is where within the data collection waves we've collected information on food and diet. And this has mainly been done using a food frequency questionnaire, but we've also asked other questions on dietary behaviours, food security, and other related nutrition questions as well in the context of general health and well-being. And it's also really important to note when this information is collected that we also have the utility to be able to link to other data that is collected on these children from other national data sets, obviously through consenting process. And so we've done that a bit in the nutrition space as well. The thing that really frames, I suppose, the study in terms of thinking about how we collect data and information that informs us about how children grow up in New Zealand is that we use these what we call research domains and themes. Basically, Growing Up in New Zealand has these 6 domains, which you can see here. So family and whānau, social context, education, health and well-being, psychological and cognitive development, and cultural identity. And these are interwoven with 4 themes which recognise our ethnic diverse population. So the domains represent the variety of influences which are considered at any point in time for each of the child in the study. And as you can see, that this lattice work is really modelled on the weaving of Ekete. And really at each data collection data point, participants are asked information around all these key domains and themes. So you can see that in terms of nutrition, we have a lot of information about food and nutrition at the various data collection from the various data collection waves, but also a lot of information that we can associate with dietary intake at those time points. And also we can look longitudinally also about how dietary intake itself can influence health and development and outcomes for those children. So today we're just going to talk to you about the main nutrition related topics which we've kind of reported on to date. And when I say reported on, this isn't only in reports for the ministry, which can be used for developing policy, but also that we've published, peer-reviewed journals. So we've looked at maternal diet and pregnancy. We've looked at folic acid supplement adherence during pregnancy. We've looked at breastfeeding. We've looked at complement in the first year of life and beyond. We've looked at complementary feeding and the introduction of solids. We've looked at early childhood education services and nutrition environments and menus for children that are growing up in New Zealand. We've looked at childhood eating behaviours, we've looked at food hardship and the effect on childhood nutrition. And there are many other topics by other researchers who've used the data as well outside of the study team. And you can actually get access to all these published articles on the Growing Up in New Zealand website. So if we just start looking at the published work on the antenatal data, so looking at the dietary intake data that we have and the nutrition associated data that we have on the women when they were pregnant. The first thing really is to demonstrate here to you is that we have a really diverse, mothers in the Growing Up in New Zealand cohort. So this is just showing an illustration of their characteristics. And so you can see that we have a diversity of age groups when the mothers were pregnant. We have a diversity of ethnicity. We have a diversity of education and also socioeconomic status. And just out of interest, for something that we're really interested in, is that 36% of the cohort in growing up in New Zealand were born outside of New Zealand, which makes for some very interesting research in itself. And also 25% are on income tested benefit when the child was 9 months of age. So with our maternal dietary data, what we did a couple of analyses. The first analysis was to look at how the women adhered to the then food and nutrition guidelines. They've obviously changed in the last year, but the old food and nutrition guidelines were pertinent for this cohort in 2009-2010. So what we did is we did an analysis where we looked at the recommended guidelines in terms of the food group servings for pregnant women, and we compared the dietary intake using an FFQ from the women in the cohort to these guidelines. Now, I'm not going to show that data because in the interest of time, but just out of interest, I thought I would share just a bit of the outcomes from that analysis, which you can also read in the publication noted on this slide, that actually only about 3%, around 3% of women basically adhered overall to all the guidelines. And if we looked at the specific guidelines, only 25% adhered to the fruit and vegetable guidelines, with 21% adhering to the protein or the meat and meat alternative guidelines. And there was also quite a high self-report of discretionary food intake, such as chips and confectionery and sugar-sweetened beverages. So that was interesting data. But then to really go on and try and understand more about dietary behaviours in pregnancy, we then completed with the FFQ principal components analysis with the data to try and understand more around the dietary patterns of these women. And there were 4 very distinct patterns that came out of that analysis using the principal components analysis. And these are indicated to you here on this slide. So these are the foods that have high weightings on these patterns. So you can see for what we named or labeled these patterns, the junk pattern was characterized by a high intake of, or more likely to adhere to the junk pattern with a high intake of confectionery, snack products like crisps and nuts, takeaway foods, hot chips, processed meats, etc. The label that we gave to the health conscious pattern was characterized by vegetables, cheese, wholemeal bread, non-citrus fruits, yogurt, dried fruits, high fiber cereals. And then we had a label for a sort of more traditional diet, a white bread type diet, which was standard whole milk, white bread, margarine, jam, honey, peanut butters, and other cereals. And then we had this other pattern too that we characterized or labeled as fusion or protein, which was characterized by noodles, rice, pasta, seafood, chicken, green leafy vegetables, eggs, and red meat. Then the next analysis that we did is we looked at what these were independently associated with. So what were the independent predictors of these maternal dietary pattern scores? And so this was very interesting. What we found was that if we looked at the junk dietary pattern, we found that it was significantly associated. So these are forest plots. So it was significantly associated with self-prioritized ethnicity being Māori or Pacifica, and it was negatively associated with Asian or other ethnicity. And then when we looked at that dietary pattern, whether it was associated with people being born in New Zealand or outside of New Zealand, we saw that this pattern was negatively associated with being born outside of New Zealand. And then when we looked at the traditional dietary pattern, we found again relationships or associations. So we found there was a stronger association or in a more positive direction for Māori and Pacifica, and a slightly positive direction for Asian. And when we looked at this pattern with education, again, we found a relationship, a significant relationship with primary school education. For the other dietary patterns, the health conscious and fusion, we found a negative association with the health conscious pattern with being born outside of New Zealand. And in terms of the health conscious pattern and age group, we found that it was more likely to be associated with negatively with being under 20 years of age or between the 20 to 29-year-old age group, whereas it's more positively associated with being 40 plus. And for the fusion diet, we found that being born outside of New Zealand, it was more positively associated with that dietary pattern. And then you can see here for fusion, for the fusion dietary pattern, there were positive associations with self-prioritized ethnicity for Māori, Pacifica, Asian and other, so for all ethnicities when compared to European. Another really interesting piece of research that we looked at in using the antenatal data set was looking at the use of folic acid supplementation in terms of comparing it to the Ministry of Health recommendations for folic acid supplementation prior to and during pregnancy. Now, this work was conducted by Juliana Teixeira, who was, we were very fortunate to have. So she was a PhD student from Brazil, and she came and did a 12-month sort of internship with us. And while she was with us, she conducted this analysis. Now, this analysis is a really good example of data linking, because not only did we use the information we actually collected in growing up in New Zealand on folic acid use, but we also, Juliana also linked it to the pharmacy data on prescription uptake of these women in terms of being able to validate the measure that we used in growing up in New Zealand, or the self-report measure that we used in growing up in New Zealand to describe folic acid supplementation. So what did we find? So we found that in terms of the criteria for classification, we had none, insufficient, insufficient, extended, recommended, recommended, and extended. And so what we found is that 13% of the women did not use supplements before nor during pregnancy as recommended. In terms of the insufficient, we found 23% did not take sufficient supplements during the 4-week prior and 12 weeks after pregnancy. Insufficient and extended, we found that 33% did not take sufficient supplements during the 4 weeks prior and 12 weeks after pregnancy, and extended folic acid use beyond the first trimester of pregnancy, which isn't recommended. And in terms of recommended, we found 8% use supplements 6 to 7 times per week, at least 4 weeks prior and 12 weeks after pregnancy, but did not use folic acid from the second trimester of pregnancy and onwards. And in terms of recommended and extended, we found that 23% achieved the recommendation of supplements used in pregnancy, but extended its use beyond the first trimester of pregnancy. So really interesting information, one about the low use, but also that women are taking folic acid supplement in quite varying, varying patterns. So basically overall, with that data, we found that 69% were taking insufficient folic acid as recommended by the Ministry of Health. So that's a quick whirlwind tour through the some of the nutrition findings from the antenatal data collection wave. So moving on into the first year of life, we had some fantastic data that we collected at 6 weeks, and then an in-home visit at 9 months, and also at 24 months of age. And so the Ministry of Social Development basically we applied to write a report for the Ministry of Social Development to look at infant feeding during those first 2 years of life. And so we used the data collection wave, as I say, 6 weeks, 9 months and 24 months to write this report. And in the report, we looked at the individual Ministry of Health recommendations around infant feeding at that time, using the food and nutrition guidelines for 0 to 2-year-olds. And we also developed this infant feeding index using each of those items in the Ministry of Health Food and Nutrition guidelines, or the recommendations in the infant food and nutrition guidelines. And so we've written this report that looks at those individual indicators, but also compiles this index, and the utility of this index and the reproducibility of the index has also been looked at or analysed in terms of from a research point of view. And we've actually written or Teresa de Castro, who's on our team, has actually analysed that data and written a paper which we've submitted and hoping to get published shortly. The other great thing about using this information from this report that we wrote for MSD is it has also been able to help inform the new eating and activity guidelines for 0 to 2-year-olds that we hope will be published, will be available very, very shortly. So these are the indicators that we use for the infant feeding report and also for developing the infant feeding index. So there are 12 indicators overall, and you can read in the report how we've developed the index and what analysis we use to develop the index. But you can see we've got a breastfeeding, a group of questions, we've got introduction to solids, we've got appropriate foods and drinks, and also we've looked at the variety of foods as recommended in the food and nutrition guidelines as well. So just to look at a couple of the individual indicators that we reported on and used in the index that you may be interested in. So in terms of exclusive breastfeeding, so what did we find? So we found that only 34% of this cohort were breastfed to 5 to 6 months, exclusively breastfed to 5 to 6 months. So obviously the recommendation at that time, and still is in line with the World Health Organization recommendation that the optimal exclusive breastfeeding is to around 6 months of age. But when we looked at any breastfeeding and the duration of any breastfeeding, it was interesting that actually 65% of the babies had some breastfeeding until 6 to 11 months of age, and 36% for 12 months or more. And so this is in line also, we asked a question antenatally to the mothers about what their ideal duration of breastfeeding would be, and 68% of the mothers said that their ideal duration of breastfeeding was longer than 6 months. So this was really, encouraging that it was in line. The duration of breastfeeding was actually in line with the, the ideal duration described by the mothers. So I'm now going to pass over to Sarah, who's going to go on and talk about the introduction of solids and also the utility and some of the results of the IFI. Thank you, Sarah.
Thanks, Claire. So this slide here is about how the age at which children are first introduced to solid foods, so they're complementary feeding. And we found 2 in 5 infants were introduced to solids before 5 months of age. So remember, if they're exclusively breastfeeding to around 6 months, we want them to ideally not have their first solids until after they turn 5 months, or World Health Organization says 6 months. So that's 40% there who are being introduced to solids early. As you can see from this graph or table on the right-hand side of your screen, the bars here in black are showing the groups where we really could do with some more assistance to help them get up. So we've got our under 25-year-olds, Māori and Pacific were quite low, and then also the ones with lower than bachelor's education. Plus, if they didn't have a partner at antenatal and hadn't attended their antenatal classes as well, they also were more likely to introduce solids early. And also families in the most deprived areas were more likely to have the solids introduced early to their infants. The other thing we noted in this data was that there was a lot of early introduction before 9 months of age to foods that were not recommended at all for infants. The previous infant and toddler feeding guidelines weren't as clear on this as the new ones that are about to be released, but there are this group of discretionary foods that really are not recommended at all for infants because of the high saturated fat content, high sugar, high salt, and this idea that they might, what research is showing now is that if you do introduce these foods early, it's setting food preferences for life for these children, which is unhelpful for a healthy eating dietary pattern. So if they're having sugar early, they're more likely to want sugary foods. So we saw here, you can see in the table, there are around 40% of children who had tried hot chips by 9 months of age, 30% had tried chocolate, 20% odd had had confectionery, sweets and lollies, and around 20% as well had had crisps or potato chips. Now, if you go further along the table, you can see that they're not having them all the time, but they are being introduced to those foods early. There were still 14% though who are having hot chips at least weekly at 9 months of age, 7% chocolate weekly, around 8% confectionery weekly, and 7% potato chips. And then we've got the figures there also for how many who were having them at least once a day at 9 months. So in the multivariate model, where we adjust for all the differences between groups, it came out that younger maternal age, non-European ethnicity, low education, no partner status, and high neighbourhood deprivation all remained independently associated with the likelihood of this early introduction of these foods at 9 months. So those are the groups we really need to reach with these messaging. If we look overall at the infant feeding index, so taking all of those variables Claire showed in the earlier slide and put them together in a score, we kind of have a nice normal shaped distribution here of, you know, people on the left-hand side of the screen there are the least likely to meet the recommendations. And then over on the right, we've got 1.5% who are meeting every single recommendation in the dietary guidelines. So that's what we'd expect, that there's around, so the mean was 70 out of 100 of the scores. So most people are getting, you know, the majority of the guidelines they're adhering to. And about 1/3 are experiencing good adherence. So we said that that was a score of 80 or more. Again, education, ethnicity, age, socioeconomic status, the usual culprits are associated with adherence. And again, that partner support and antenatal classes also associated with better adherence. We wanted to make this work on the infant feeding index really translatable for policy, so that when we were writing the new infant and toddler feeding guidelines, we would know where to put the emphasis. And when you dig down into the data, there's 4 guidelines from the previous set that really came up as key for us to highlight if we wanted to focus on reducing inequities. So the ones where we saw the greatest difference between ethnic groups and socioeconomic status are these 4 here. So, and also where they had very low adherence in the whole population as well. So the exclusive breastfeeding to around 6 months is clearly a guideline that needs still a lot of promotion, even though the World Health Organization has been pushing this one for a long time. You know, we can do a lot better in New Zealand with this one. Avoiding cordial and juice. There's a lot of sugary drinks introduced early, which again, setting that taste preference for sugary foods and drinks, and introducing excess calories at an early age, and displacing breastfeeding as well. The avoiding sweets, lollies, chocolate, hot chips, those foods we talked about before, and the vegetable and fruit recommendations too. So there's 2 serves of vegetables and 2 serves of fruit a day, trying to bring those up. So what this really raised for us was what are, you know, and the question we really put to all of you as well is, how can we best support and engage with the groups where we have this really low adherence for these 4 guidelines and a high adjusted relative risk, which means they're much more likely than other groups not to meet these guidelines. And the arrows are showing the particular guidelines relevant for these groups. So young mothers and women with no university education were much less likely to have exclusively breastfed to around 6 months. Māori and Pacific mothers, they have 4 arrows going into those ones, and mothers with no partners. So the exclusive breastfeeding, all of the 4 guidelines were much lower for them. Asian mothers had 3 of these 4 guidelines of relevance to them, and mothers living in areas of high deprivation, the only guideline where they were actually more likely to have a high adjusted relative risk is around the vegetables and fruit, which to me really made me think about, okay, what are the barriers to feeding your infant fruits and vegetables? It's a socioeconomic barrier and access barrier. So that's borne out in this data. Now, the other large piece of work I've done my PhD on with this data set was around early childhood education services and the nutrition that's provided to children in these services, either from the service themselves or brought in lunchbox from home. We matched the Growing Up in New Zealand children with the early childhood education database, and the parents told us the names of the services. Then we did a survey of the childcare centres themselves to look at analyse the menus and look at their policies and analyse those. What was found was that most childcare menus didn't meet the recommendations for 50% of serves for each of the food groups. So that was seen as like a minimum amount that they should be serving was 50% of the daily recommendation for a child's intake. But where the menus could particularly be improved was around dairy and grains, and also variety, vegetables in particular, often only carrots on a menu for the whole week. That was the only vegetable, or broccoli once. So yeah, we could really improve the menus by focusing on vegetables every day and as snacks as well as main meals. And also there were too many sometimes and occasional foods served greater than the recommendations. So quite a lot of services had occasional foods served daily, so biscuits or cakes. And with this work, we then developed with the Heart Foundation a celebrations guide for early childhood education services to try to get them to think outside the square really around what to provide on birthdays and other important cultural celebrations that they do basically weekly in childcare centres. There's a celebration or another going on. One of the most interesting findings for me was that the quality of the menus wasn't related to the cost. So it wasn't related to how much money they spent on food. In fact, some of the really expensive menus didn't meet the dietary guidelines. They might have been organic, but they weren't actually meeting a child's daily intake, or half of a child's daily intake of what they should have been having. Also, a lot of the biscuits and crackers, I think, were pushing the menus costs up, which, yeah, they didn't really need. And a lot had really innovative ways of accessing fruit and vegetables for their services. So they might have a good scheme going with some local producers, and we're getting those at cost and in bulk, which was great, and keeping their costs down. And then the other main finding from the thesis was that participation in the Healthy Heart Award was associated with a much better menu. And it was any level of participation, just showing a willingness really to engage with nutrition was, they didn't even have to have the Gold Award shown here. But obviously the ones with the Gold Award were making an effort to get out into the community and actually spread nutritional messages, which was fabulous. As I said, there's been quite a lot written, so lots of publications there for you to check out if you're interested in food in the ECEs. And the third publication down there compares the ECE environment with the home food environment. So are children being rushed to finish eating in both of those settings, which is quite interesting from a more behavioural point of view. Developing children's kind of ability to know when they're full, to self-recognise hunger and satiety, and yeah, there was a lot of interesting research come out of that. And then the last topic we're going to talk about is food hardships. This is a report we released just recently that was part of research we did for the Ministry of Social Development in collaboration with the Department of Prime Minister and Cabinet and the Ministry of Health. So there's quite a lot of stakeholders involved, but it was great because we could feed into policy directly, looking at 3 different types of food hardships experienced by these children and growing up in New Zealand during their first few years of life. So you can see down the bottom here, the 3 at the bottom of the graph here, is forced to buy cheaper food to pay for other things. Did they make use of a special food grant or food bank? And had the mother gone without fresh fruit and vegetables to pay for other things? And that was when their children were 9 months of age and 54 months of age. This graph here shows across that whole preschool period had the child been living in a family that experienced that food hardship. So you can see very high proportions of Māori and Pacific mothers reporting, well, it was Māori and Pacific children whose mothers reported that they had been forced to buy cheaper food to pay for other things. And that's actually across the other age groups, ethnicities as well. It was basically over 50% of our cohort, the mother reported that. But even these other food hardships, which might be seen to be more serious, I guess, the making use of a special food grant or food bank, 35% of Māori and 40% of Pasifika children's mothers had made use of a food bank within the first 5 years of their life. And decent numbers in the other groups as well. So that really made us sort of sit up and look at this data. Remember, it's pre-COVID. This is back in the late, around 2010 onwards to 2012. And there are a lot of families really doing it hard in those first few years of their children's lives. The point of this research, though, was to show that these food hardships were actually having an effect on the children's nutrition themselves. So it wasn't just that the mum was going out without fresh fruit and vegetables. Not surprisingly, that also influenced what the children were eating. So compared to other children in the cohort who didn't have food hardships but were of a similar socioeconomic status, these children whose families were living with food hardship were more likely to have stopped breastfeeding before 12 months of age. They were more likely to have had fewer serves of fruit and vegetables at 9 months, more likely to have tried unhealthy foods and drinks, remember back to that indicator, before 9 months of age. And they also had less variety of fruit and vegetables at 4 years and were more likely to have soft drinks at 4 years. So their whole diet was really predicated on cheap, easy to access foods. And even after adjusting for the differences in education of the mother, their socioeconomic status, etc., they still have these nutritional outcomes that are concerning. So that was a real whirlwind tour, everyone, of everything we've been doing at Growing Up in New Zealand over the last few years for nutrition. We still have a lot of projects on the go, which we can't wait to share with you. The main one being this first thing that Claire mentioned before that Teresa's been working on, is these dietary trajectories through early, middle and late childhood to be able to show the effect of the food that's being eaten on both BMI and other health outcomes. We're updating this infant feeding index, and that's going through peer review at the moment, so should be out any day. Plus there's this relationship, as I said, between early childhood diet and body size. We've also collected quite a lot of information on the school food programs that are now starting to be rolled out, so across the 8-year and 12-year data collection waves, plus what parents thought of preparing lunches was collected at 8 years, so before the rollout, to help inform DPMC's policy there. As I said, we've got this food insecurity data at 8 years, and now we're creating an index with that, similar to our infant feeding index, and we can compare it with the earlier data I showed. Also at 8 years, there was an interesting scale on food neophobia, so children who are fussy eaters, as well as, fussy eating, sorry, we had in preschool period as well. We're going to compare that with the food neophobia scale at 8, so children who are actually afraid to eat different types of foods. The partner's dietary changes, Claire mentioned we've collected data in that antenatally about the partner's diet, so we have a student looking at that now. And also growing interest in this area of ultra-processed foods and sustainable diets. So we have students coming through really interested to look at the food frequency questionnaires with that lens of, okay, which foods are more ultra-processed and what effect is that having on children's nutrition? If you're keen to get involved, which hopefully you all are, there's so much data there for us all to get into. We're always keen to hear from people who would like to do their masters or PhDs in this area, or who would just like to read the reports, if you can't find anything that we've referenced here in the slides, do get in touch, send us an email. But yeah, we're just keen to see this data used as widely as possible. So that's the whole point of this webinar. And I just want to say a big thank you to the families involved with Growing Up, over 6,000 of them, who give so much of their time to answering these food frequency questionnaires alongside many other questions about their children's lives. The funders of this study, MSD, and the Children and Families Research Fund did fund a couple of the studies we've mentioned. We've had lots of different researchers involved to date from across different universities and countries. Our lovely Brazilian colleagues have been fabulous, and Amanda de Cesar do Otago in Wellington has been involved in the food and insecurity work. Our policy collaborators, thank you to you at Ministry of Health and Department of Prime Minister and Cabinet. And yeah, we're happy to answer any questions you might have. Thank you.
Thank you so much to Claire and Sarah. What a wealth of information. This is just such a rich source of data, and it's so fabulous to see that this database is available for people to do their Masters and their PhD on. I'm sure there's so much more that can be found out. I'm intrigued and always have been. I've read the reports as they come out and been to the launches and just fascinated by the type of interactions and the data that's collected, as are a number of people who have asked questions for us today. So just starting off, a few questions around folic acid. And is the low intake related to prescription matching? Is there any data looking at education provided by key providers such as midwives? And is there an ethnic breakdown related to the folic acid intakes?
Yeah, they're great questions. Thank you very much, and thank you everyone for your time today. In terms of the first question, we don't have information around the lead maternity caregiver in terms of what information that they provided or the support that they gave. The only information we have around diet and nutrition with regards to the LMC is who they trusted most to provide them with nutrition information. And that was quite interesting in itself, because they still trusted more their GP to provide them with nutrition advice during pregnancy than any of the other. I mean, they still had trust in other LMC providers, not that GPs really provide, that was interesting in itself, maternity care in this country anymore, or haven't done for a long time. But it was interesting that the participants said, or the cohort said, that the significantly felt that they trusted their GP the most when it came to providing them with nutrition information. So unfortunately, we don't have information around the advice, whether they got the advice specifically on folic acid from the midwives and how that advice was given. In terms of, yes, there were differences in terms of planned and unplanned pregnancy and use of folic acid and ethnicity and socioeconomic status. So there were definitely some sociodemographic and ethnicity associations with pregnancy, mainly because there were more unplanned pregnancies in some socioeconomic groups and some ethnicities, and in the unplanned pregnancies there was obviously not many people taking folic acid as should be, as prescribed. But interestingly, even in the planned pregnancies, people still weren't taking folic acid as recommended or prescribed, and there was also a relationship with socioeconomic status and ethnicity in that, and we can share the publication that's in that publication as well.
Thanks, Claire. There seems to be quite a number of questions asking about the type of education that's working or not working, and I'm well aware that this cohort study is collecting data. You're not actually doing education, and so is there a theme that you're finding about a lack of education happening, or a lack of appropriate education? Is there something that you could comment on there?
I mean, I think the while this cohort was growing up, there were changes from the Ministry of Health to the HPA around who was doing health promotion advice to the public, and maybe some messages got lost in translation there as well, because it does seem like we needed, so the guidelines are written for health professionals to help them, the eating and activity guidelines, for them to know the best available evidence, and then they need to share it with the public clearly, and via sort of brochures and brochures work, or websites, apps with the communities, and HPA kind of take that role. So yeah, it's definitely something we could do with more education to the public. We don't have a lot of information in growing up about that, apart from the questions Claire just referred to around who do you trust most for your education, or where do you get your education about what is a healthy diet for your child. We've asked that question too at 8. A lot of people still rely on their families and friends, for advice on feeding their infants, and toddlers and children. So would be great to see more work in this space.
And unfortunately, we didn't really, it's hard to measure behaviour change around education in this kind of survey. It's not the appropriate way to do that. We can look at what the policy is at the time, what the policy and what's available at the time, what people may have access at the time. And so there may be, plentiful education opportunities to access the education, but it's then quite hard to measure the actual uptake of that education, because what we're saying by proxy is that because people aren't, meeting the recommended dietary guidelines, or they're having to, access food banks, etc., that's not an indication that the education isn't working. It could just be an indication that actually, there's issues around food access which are related to, poverty and other things. So it's a very hard thing to disentangle, if that makes sense.
Very complex system, isn't it? Given that so many people, or so many children are at early childhood centres, do you think there's a place for the Ministry of Education to incorporate some sort of nutrition into their licensing?
Yes, always. Yes. So there are regulations around providing healthy food and promoting healthy eating in early childhood education centres, but that's where it stops. So it's just that wording. It's not very specific about what they should be doing. And nutrition is part of the curriculum as well. There's just such a diversity of interpretation around the regulations, and zero enforcement of that, really. As well, was what we found. So the ERO reports, they're not designed to be looking at the nutrition environments within those centres. So we would probably need the public health units to pick that up more. They at the moment only go in pre-licensing stage to check about the food that's being provided, and there's no actual analysis of the menus unless the centre wants it themselves, requests a dietitian to look at it. So yeah, that's definitely an area that can be improved. Right. I noticed Robin did ask about most ECEs do not provide 50% of food groups, what percentage did and didn't. Definitely check out the paper on the menu analysis, because there was 10 indicators we were looking at across the food groups and across variety and the quality of the food. Most of them were meeting their fruit and vegetable serves because they just meet it with fruit, and that was together, whereas the vegetables were low. And so, there's a lot more detail there you can go into.
Yeah, I've always thought that fruit and vegetables should be separated out for that very reason. A couple of yes or no questions. Have you looked at oral health and also iron intake?
Yes, so there has been quite a lot of research recently around oral health and using the dental health, also data linking to the dental health records, so looking at decayed, missing and filled teeth, and looking at the association of a number of sociodemographic indicators, but also dietary intake as well. And so that's been published now by Simon Thornley and his group from Population Health. So that has been quite interesting, and they're now following that up, looking at more of the data linking to healthcare records on children that need teeth extraction. So those that have had to been admitted to hospital to have a tooth extraction. So yeah, we can certainly provide you with the links to those publications.
Fascinating. Yeah.
A bit about avoidance of foods too. I should.
Yes.
I mean, there definitely is a lot more perceived intolerances and actual allergies out there around food, and this has impacted a lot on what early childhood educations can serve. Obviously, there's I think the bit about dairy, you know, the actual allergies are still very low, so I don't think that's the reason they weren't serving them, and they should still be serving alternatives anyway, even if they aren't serving the milk themselves, because children still need calcium. So yeah, a fortified milk would be suggested. But we have covered more detail on this in the 8-year and the 12-year as well, around mothers and partners and children's avoidance of certain food groups. So yeah, watch this space, because I think there's more coming out in this area. And also around fussy eating, you know, we just realize it's such a growing topic of interest because of the growing numbers of people reporting troubles with having their children be fussy eaters. So yeah, I think there's more to do in this space.
Fabulous. Sarah and Claire, this has been a wealth of information, and you've just touched on a few of the topics I know that you could talk about. Very, very delighted to have you here today. Thank you so much for putting all the effort into this research and sharing it with us, supervising all those wonderful students that you've had that have been delivering some of this research too. Really appreciate your time here. Next week, we have Nadia Lim coming to talk to us. Nadia has recently moved to Central Otago, and she's going to tell us about her life living off the land. So we look forward to you joining us on next week on the 9th of March. And a short survey is about to pop up on your screen for those of you that are watching. If you could just collect or take a couple of minutes to complete this data, it's very useful for us moving forward to help improve our webinars week by week. Sarah and Claire, thank you so much. Appreciate your time. Have a wonderful week in lockdown. Enjoy it if you can, and ka kite anō to everybody here.
Kia ora, thank you.
Kia ora.